Unless you want to put to say? Okay. I guess we're ready, right? Maybe. Hey, Remy. You know. Jennifer, you're after I am, right? So, let's do this. Because I can go. Good afternoon, everyone. Good afternoon. Welcome to the Peach State session here at the 2025 Fall Medicaid Fair. My name is Brian Vaughn. I will be kicking us off today representing Peach State Health Plan. I am the Director of Population Health Strategy for Peach State, for our PHCO department, and I will be speaking alongside with my esteemed colleagues on our programs and our operations as an organization. I also have some esteemed colleagues that are in the audience that are here as well that are representing Peach State Health Plan as well that could answer questions that you may have about what we're going to be discussing today. So without further ado, let's kick it off. So I want to start off talking about our social determinants of health. And what do we mean by our social determinants of health, and how do we approach it as an organization? So you can see here on the slide, it talks about our consistent and equitable SDOH screening is a cornerstone of quality care for all of our Peach State members. So what does that mean, to be consistent and equitable? First, consistency is in that we are screening every member at every appropriate stage in that member's experience, in that member's journey, right? So that we are using the right standardized tools and the assessment instruments to uncover their SDOH needs. What we mean by equitable is that we're applying those screening protocols across the board, uniformly to all of our members, to ensure that we are culturally appropriate and language accessible in our medium of interacting with those members. You can also see on the screen here that there are specific focuses that we have for our SDOH needs, such as housing stability, food security, transportation, and education and employment, which are top drivers for the areas that we look at from an organization for our members here at Peach State. So how do we screen our members? So there are various different ways that we screen our members to uncover their SDOH needs. Number one is that we have member-facing staff who conduct home visits and member events that allows us to interact with the community so that we can uncover these needs. We also have a dedicated care management team that works closely with our members and outreaching to our members either telephonically or through our in-house assessments. And these assessments and these conversations help us to uncover what situations are actually happening in their member journey, in their life on a day-to-day basis, and then what are some things that we can do to partner with them to help close those gaps. We also have our collaboration with our partners and our providers, where our members are conducting and going to their annual visits, and with those providers, they are also providing referrals. So based upon those conversations, the providers are also interacting with members to uncover any type of needs that they may have, and also sending in those referrals over to Peach State. And lastly, the members can self-referral themselves via the Peach State website. So what does that look like? What does our members have access to? So I just mentioned the Peach State website. So here on the screen, you can see that this is a site that our members can go to. They can self-referral themselves. They can fill out the information. This information comes over to our department, and then we can perform outreach with those members to ensure that they are getting the care that they need, that we can receive it, is going to the right team, and that we are responding appropriately to those members' needs. We also have a tool that is known as Find Help, which is a very robust system that helps us to find community resources for our members. Our members have access to this on our peachstatehealthplan.findhelp.com website as well, where they can go and find resources as well and internally, if we are in conversations through an assessment process with our members, we have access to find help, and we could also offer those services to them as well. I mentioned that we do various assessments, and one of the assessments that we do is a Drivers of Health mini screener, which when we are interacting with our members from an assessment perspective, we can uncover those needs right there in that moment with that member to find if they do have any SDOH needs, food, housing, transportation issues that we can resolve. And so we go through that assessment process, and that assessment is sent over to our care management team, care coordination team, where they are working diligently to close those gaps for our members. And lastly, I mentioned that we have our provider referrals. So our providers we work closely with so that we can ensure that we have a very collaborative process so that when those needs are uncovered, we can be working collaboratively with those providers to resolve those issues. So who does the screening? Right, I've already mentioned a couple of those. Number one is that we have our primary care providers, which we partner with on a consistent basis. Once again, that is done through the annual visits, the first-time visits, which gives us the ability to start that baseline of documenting the needs that the members have, and also to establish a regular screening process as well. Because we know things can change in that member's journey and member's experience, so we want to keep abreast of the things that are going on. And we have, number two, the ongoing care with our care managers and our care coordination team also, who are performing telephonic outreach and who are working with those members consistently on a regular basis, once again, through that member's experience. And then number three, we have the community touch points with our community health workers, who are actively involved and actively engaged in the community, visiting members and hosting member events. Because this helps us to tie back that community focus, that community orientation back with our members so that they could see that we are in the community and that we are actually engaged in what's happening. And number four, I already talked about the members can self-assess on our website as well. I mentioned some of these previously. We look at our SDOH tools and referral systems. The health risk screening is a screening that we do in the very beginning with our members to uncover some of those needs as well. So that just gives us a baseline and a historical health perspective of our members so that we know where they are. I already mentioned our SDOH mini screener, which is an assessment tool that we use. It is used by our clinical and non-clinical staff to assess what is happening in that member's experience. And then we have a secondary housing assessment, of course, which is looking at the member's living condition, their housing condition, safety, cost, and we provide ways to help our members in those dire situations. And then we have our food security assessment, which helps us to uncover any situation where they may be in a situation where they have a concern about food security. And then once again, I mentioned our referral systems. The two, once again, is our Find Help system, which gives us the baseline and overall insight into our members, who the members are, what categories they're searching for, what counties they live in with the highest activity, so that then we could start to really focus and concentrate on members in those particular areas, and the number of referrals that are made by a particular organization. So our Find Help reports help us to see a wealth of information that we can pull from. And then our Community Connections Helpline, of course, is a toll-free, peer-based hotline that members, caregivers, and providers use in uncovering and removing these social barriers as well. And you can see here, based upon the PowerPoint, it's connected to our national and local community services and resources, and it's done by our clinical and non-clinical staff. So when we talk about how do we track this, how do we find out trends, and how do we report our SDOH data, some of this I've already mentioned, but the very first indicator we have is our KPIs, right, our key performance indicators. And we have an internal dashboard that we've built, which I'll give you a preview of that here in just a moment, that helps us to identify these needs through assessments and screener data that we compile and that we look at on a consistent basis to identify where we are, what are we looking at, what areas have high concentration, and where can we really put our focus in to help our members who are in need. Next, we have a predictive modeling program called Impact Pro, which helps us to identify vulnerable members that have high SDOH needs that we can reach out to immediately and get that member some resolution to what's happening in their life. And then thirdly, we have our Find Help reports, which I mentioned several times, which gives us that data, that information that helps us to identify what's happening in the member's life, where the highest concentration of activity is happening, so we can focus our resources in those areas. So here is the example of our SDOH dashboard, our KPI dashboard, which you can see we're looking at it by location, we're looking at it by those DOH needs in that particular area. What are some of the main indicators that is happening, so we can see from a population perspective where our greatest needs are. You can see over on the right-hand side, which would be my right-hand side, the total population by member that we have that are currently have SDOH needs, the member screen, how many members are positive for those SDOH needs, how many unique SDOH screens have been completed, and our screens versus member screens from a positive change perspective. So it gives us, our KPI dashboard just gives us a lot of data that we can pull, that we can look at, that we can start to talk about strategies on how to resolve some of the issues that we may be seeing from an operational perspective that helps us to really target and identify those SDOH needs for our members. And lastly, how do we close the loop, right? There has to be a closure process to this to ensure our members are getting the access to the information and the resources that they need. So we have a very closed loop process that helps ensure that we're fostering accountability and collaboration with our community. So we have a 7-day follow-up process to confirm that the member has received the resources that they were looking for, or to identify any additional resources that they may need, and to remove any barriers to access to those community resources as well. So this is a very detailed, integrated process into the operations of what we do within Peach State Health Plan, and we just to ensure that our members are receiving the care that they need and the issues can be resolved and gaps to be closed. That is the end of my section. I will open up to ask, what questions do you have? Yes, ma'am. So there is if you go to peachstatehealthplan.findhelp.com, that is,
right.
Yeah, that is correct.
I just wanted to confirm that.
Yep.
And then the other part is, you know, if you see that maybe the member came to your website, do you also see that utilization of that member or the children that that individual has that are enrolled? Because I'm wondering if there's a way to have this bi-directional communication with that individual's medical home so you can collaborate on addressing those needs, or maybe get additional information or see, you know, why there's a barrier, et cetera. I just feel like that data is so rich, and I love how you're analyzing it and doing the close the loop, because in pediatrics we find that's very significant. It's not just enough to give the resource as much as it is, what was your experience accessing that resource? How can we improve that experience, you know, for the member? So I just really appreciate that part of it, and I guess I'm wondering too if our legislators would benefit from hearing about the social drivers of health or health-related social needs that you're identifying, so that they too can perhaps create policies or systems that can alleviate some of those things, because it's going to be by zip code. It's going to be significant to legislators. So I would encourage, I know everybody's doing that today, so it might be something worth doing.
Yes, to piggyback off of that, keep in mind that even if the member self-referrals, there is still an assessment process that we go through with the member, because the information, what they put on the website, we're digging deeper into what they provided so that we can uncover everything that is happening within that member's journey. So once the self-referral comes in, then our care coordination team is performing outreach with that member and conducting a very thorough assessment. All right, I will turn it over to my esteemed colleague, Jennifer Morris, who will be talking about provider complaints.
Good afternoon, everyone. Again, my name is Jennifer Morris. I am the Provider Relations Trainer, and we're going to look at provider complaints and talk about that just a little bit. So as you can see here, we actually have identified our top 3 complaint categories. The first one being 42% claims and billing issues, and then you have 44% balance billing, and then 14% is access to care. So once we identified those top 3 categories, we then started doing a deep dive and looking at, what are some of our successes? What are some lessons we've learned? As well as some improvements that we could put into place to actually lower or decrease the number of complaints that we are receiving in these categories. So for access to care, some of our successes would be improved member outreach and documentation. One of the improvements that we put in place is expand provider education and address timely access to care for our members. On the claims and billing issues, faster claim processing. We all want that, so we have actually, looked at that. That is one of the things that we have, pride ourselves on is how fast we can turn around your claims payments. An improvement is expand provider education and billing guides. So we're always developing new tip sheets, new tools, new guides for you guys to help you when you're billing and just helpful tips and information. On the balance billing side, it's one of our successes, of course, is member protection through outreach. Outreach is always the key. One of our improvements is to strengthen provider onboarding and contract training. So now we're going to talk a little bit about the Georgia Pathways to Coverage program. So this particular program is where, let me back up. This particular program, the providers are required to participate in ongoing education and training, and we also offer a lot of tips and tools and FAQs and guides out on our website. So as you can see here, some of the things that we have listed out there for you all to make this process for this program a little bit easier for you to maneuver. We have who is eligible, so we let you know the eligibility guidelines for the program, how the member is to maintain that eligibility, what do they need to do to stay eligible, qualifying activities and what that means, good cause exceptions. We also talk a bit about disabilities information and how to renew your coverage, and of course, always getting support for those members. We also list some helpful links for you on the website. We list an FAQ, the provider manual, and of course the Georgia Families Handbook, as well as other things that would be great tools for you. So the Georgia Pathways to Coverage program, those members are also eligible to receive the state plan benefits of all the other Medicaid groups. And some of those services you will see listed on the screen here. You've got your medical services, your vision and dental services, as well as those behavioral health services. And we do have information on our website, as well as our provider manual, around provider responsibilities. So we talk about the purpose of the PCP being the member's medical home and the importance of that, supervising and coordinating their care, maintaining coordination of care, inpatient and outpatient services. There's information on there about your vision and dental providers, those behavioral health providers, as well as the specialty services. So effective October the 1st of this year, the copays were implemented for this program. Now those members that are 21 and under are not held to these copays, so they do not have to pay the copays if they are 21 and under. If a member does present to your office and they are in line with the copays and they have to meet those copays, if they cannot pay, you cannot deny them service. So again, 21 and under are not applicable for the copays. They were implemented on 10/1, and you cannot deny service if a member cannot pay that copay. The Georgia Pathways program does also offer retroactive coverage. It is effective the effective date is the first month in which the member actually applies for the program. New members will be retroactively covered through the fee-for-service, but then after they are approved, within 2 days, they then roll over to a CMO. And that is all for me, so I'm going to turn it over to Kenyetta, and she's going to talk to you about prepayment review. Thank you.
Hello, my name is Kenyetta Smith, and I am the Fraud, Waste, and Abuse Program Manager for Peach State Health Plan. I want to talk to you today about prepayment review, our process. So here we go. So the overall for Peach State Health Plan prepayment review process, I want to talk to you about the rationale and the implementation of prepayment review. So the purpose of prepayment review process supports payment accuracy and program integrity by ensuring that the submitted claims comply with healthcare regulations and accurately represents the services rendered to the members. Now, the rationale behind the implementation of prepayment review is to better understand and validate the services being provided. A provider may be placed on prepayment review to audit the documentation supporting those services. Under prepayment review, the claims are reviewed and may be denied prior to payment if the documentation does not substantiate the bill's services. So this next slide just kind of shows the performance matrix for Q1 and Q2 of 2025. In total, for those 2 quarters, we had 37 cases. In January, we reviewed 227 lines of services. February, 129. March was 223. April was 263. May was 163. And in June, we reviewed 74 lines of service. Now, providers they get notification and implementation of the timelines. So, formal provider notification, the provider is notified via certified mail, by FedEx, or secured email at the time prepay is being initiated. The letter includes how to identify services denied under audit and where to submit the medical records documentation. The timeline is the provider has 30 days from the date of receipt of that notification on their EOP to submit the medical records. The outcome of the review. If the documentation supports the services billed, the claim will be promptly paid. If documentation does not support the services billed, the claim will be denied with a clinical denial code. For every service denied, the provider will receive a letter to explain the rationale behind the denial and their appeal rights if they are not in agreement with the denial. The next part will instruct how to upload the documentation if you are placed on prepayment review. So Peach State, we offer 2 convenient ways to submit these requested records. The first one is through a provider portal. Documents may be submitted via the Peach State Health Plan portal under the reconsideration claims section. You have to select audit medical records requested from the drop-down to ensure that the records are routed according for review. For more information regarding the provider portal and to get enrolled, there's the website that you can visit for more information. And if the provider needs to mail in the records, alternatively, hard copy documents may be submitted by the mail. To assist us in processing the records reviewed, a submission by mail should include a copy of their EOP, explanation of payments. And the mail address is noted there on the slide. As a point of contact, if a provider is placed on prepayment review, it would be myself with my email address there, or prepayment review has its own mailbox which is noted here, SIU Prepay Inbox at Centene.com. So meeting the prepay criteria and reducing errors. The criteria and process for removing a provider from prepayment review. The provider must consistently comply with documentation and billing accuracy and achieve an approval rate of 85% before they can be considered to be removed from prepayment review. Some of the common errors we find are incomplete or missing documentation often causes claims to be denied. It delays payment and impacts the provider. We have code submission issues as well. Incorrect codes and misunderstanding submission requirements lead to claim process errors and rejections. And that is it. If you have any questions, I'm here to answer any questions you may have. If not, I will pass it over to Remy so she can talk about autism.
Good afternoon, everybody. I'm Remy Rodriguez. I'm the Vice President of Behavioral Health Operations for Peach State. Thank you so much for joining our seminar today. I am going to be speaking with you about, sorry, technical difficulties.
I'm afraid to hit. There you go. And yours, President. Thank you.
I'm going to talk to you, I'll be speaking with you about case studies on pediatric autism. The purpose being to highlight the services that are provided through our case management and to just illustrate some of the things that are available to our members in addition to all the great work that you do as treating providers. First, I'm going to talk about a member who's 12 years old, African-American male, living with his guardian in Braselton, Georgia. Diagnosed with autism, and this was escalated to a rapid response team via the mother who was having difficulties with housing issues. When the case was escalated, immediately we assigned a multidisciplinary team to the case, comprised of a behavioral health case manager, as well as a social services worker. The team immediately convened to review the assessment of the case and determine what the immediate needs were. In this case, there was immediate need for behavioral health stabilization as well as social stabilization. The family was in crisis due to the fact that the mother had been asked to take the child out of school and homeschool the child because of the severe autistic symptoms. And in turn, she lost her job and was about to be evicted from her home. We employed a family-centered approach and did a comprehensive assessment in collaboration with the mother where she had input into the care plan and determine what some of the barriers are, as well as the strengths of the family. The guardian started to participate in all treatment team meetings and agreed upon a cadence of the case manager reaching out to her and being able to work on her case. We also identified all the benefits that the member needed to support the family stabilization at that time. We looked at what were the needs and how we could access and make them available to this family. We first secured an ABA provider and a backup provider to ensure that the youth was back in treatment and not just on homeschool and was getting regular ABA services. Then we also refer the family to a Care Connections Plus program, which allowed her to have a cell phone and be able to communicate not only with us on a regular basis, but communicate with the treating providers as well as assist her in her job search. Our social services team started to work with the landlord to figure out how we could assist in the eviction and avoid the eviction, as well as started to find support services so she can secure a job. We looked at the whole case from an equity perspective and using an equity lens to ensure that we were looking at the holistic case, both assuring looking at the housing instability, the financial strain, as well as the technology gaps, and to ensure continuity of care for the child. Using flexible funding, we were able to work not only with the landlord, but also with legal aid, and be able to secure funding for her not to be evicted, and to ensure that she was able to continue to support her child through treatment. We also work across systems and work with the school to get an IEP and able to impact not only the care plan, the school needs, but also the social determinants of health. The final outcome was that the member was stabilized both in the behavioral and social needs. He resumed going back to school. He obtained the behavioral support he needed. The family avoided eviction. They secure stable housing. They secure additional income through SSI benefits, as well as we help the guardian obtain employment. This is a presentation of a child case. I'm now going to do a case study of one of our adult autistic spectrum disorder members. This is a 19-year-old female residing in Evans, Georgia, with her mother. The diagnosis, as I mentioned, is autism spectrum disorder, and she was transitioning from the pediatric system to the adult system, which sometimes is very difficult for our members as they progress through their Medicaid benefits. Again, this came through our rapid response team, and it was an escalated case because the member needed urgent behavioral and medical services. Immediately, we put a team together to assist with the transition from pediatric to adult care. The team comprised of a behavioral health care manager as well as an interdisciplinary team that could meet both the social, medical, and behavioral health needs, as well as to ensure preventative care was not lapsed. Within days, we completed a comprehensive assessment and secure psychiatric follow-up, which was the most immediate need. Because the family lived in an area where there is a lack of psychiatric providers, we work with our telehealth network to be able to get a telehealth psychiatrist and ensure that they could get convenient care that was able to continue with their medication management. A comprehensive assessment was also completed, collaborating with the family so they have input both on the barriers and the strength and the desired outcomes. We maintain weekly contact with the member and the family to continue to assist with care coordination. As I mentioned, we secured psychiatric services via telehealth and as well as we coordinated care to secure a GI and a dietitian in the area to serve her medical needs. With the equity lens, we looked at the inequality of young members transitioning from a pediatric system to an adult system, particularly when there's a developmental disability, and worked across systems to ensure that the member had a smooth transition in the process. Utilizing telehealth, as well as additional support services from our case managers and social services department. The outcome was to improve behavioral and medical stability, medication adherence, consistent access to behavioral medical services were established, and a successful transition from the pediatric system to the adult system for future support. I'll take any questions. Yes, ma'am. Yeah, she's right behind you.
Hey, Remy, this is Elizabeth from Stillwaters in Augusta.
How are
Hey.
you, Elizabeth?
Good, thank you. I have a question, if I could get some clarification regarding an email that I just received. It's regarding behavioral health exclusion removal. I don't know what this is regarding.
Yeah, it's a little bit confusion. What about if I meet you here afterwards and I'll explain it to you?
Thank you.
Perfect. Any other questions? All right, then I am now going to turn it over to my colleague Tara Freeney, who's going to talk with you about value-added benefits.
Good afternoon. That's all right. I am Tara Freeney, Senior Director of Operations at Peach State Health Plan, here to talk about our value-added benefits. And our value-added benefits are extra services that go beyond Medicaid offered by the state. We want our benefits to be accessible. They are accessible, innovative, and member-centric. And we also work very closely with our PHCO team to address any social determinants of health. The purpose of our VABs: improve, boost, enhance, and elevate. We want to improve health outcomes. We want to address social needs like food, childcare, and education. We want to boost engagement and retention. Everyday support builds loyalty, especially during renewals and transitions. We want to enhance our quality scores and promote prevention and reduce costs. And primarily, we want to elevate the Peach State Health Plan member journey. We want to increase overall member satisfaction. Here's a list of our benefits. I won't read through them all, but some of the benefits that we really get a lot of great feedback are our Costco and Sam's wholesale membership. We do a college scholarship. That gets a lot of feedback, a lot of great feedback. Our over-the-counter items, our mom's meals. We also have the mommy store, summer camps, and youth extracurricular activities. So we offer a wide range of value-added benefits that support our members. And what does our selection process look like, and what are our principles as we select our value-added benefits? So we want our principles are member-centric value. We're gonna focus on what our members truly need. We wanna ensure benefits are exclusive and accessible to all eligible members. We want to have strategic alignment. We want to align benefits with our overall mission and goal. We want them to be cost effective. We want to balance value and financial sustainability. We want to differentiate. We want to offer benefits that set Peach State apart. We want flexibility and scalability. We want to choose benefits that grow with our membership base. And we want to strengthen the Peach State Health Plan member connection. So what is our process? So first, we review the state agency priorities. We assess current member needs, SDOH, economic conditions, health status, and trends. We gather member feedback. We leverage our surveys. We leverage our partners and member services to find out exactly what our members need and what are they calling into Peach State about. We review the financial impact. We want to offer the moon, but we all know that we have financial responsibility. We engage our member-facing teams. We collect insights from our PHCO team, our community relations team, and our member services team. Finally, we finalize our recommendation, and we have our executive review and approval. How do we manage our performance? First, the eligibility criteria is reviewed and the VAB is processed. The VAB is then activated and captured, and we track our utilization via monthly reporting and vendor invoicing. So we monitor our VAB's performance quite closely to ensure sustainability throughout the year and coming years. Any questions about our value-added benefits? Thank you, and I'm going to turn it over to Annette Zerby, our compliance officer.
Hi, I'm Annette Zerbe, Compliance Officer, Peach State Health Plan, and I realize that post-lunch talking about legislation is probably going to put you to sleep. I apologize now. So I'm going to talk to you about the One Big Beautiful Bill Act. We refer to it as OB3 because it's much easier to say. It was signed into law July the 1st, and the Congressional Budget Office is predicting about $1 trillion in reduced or in savings, I guess you could call it, and 7.5 million people losing their Medicaid coverage over the next 9 years. So there's a significant impact to the Medicaid program overall through this piece of legislation. Okay, just good deal. So today I'm going to talk about three things. I'm going to talk about work requirements, I'm going to talk about retroactive coverage, and then I'm going to talk about eligibility determinations. What does it mean to us as a CMO? What does it mean to you as a provider? So work requirements. You might think to yourself, no big deal in Georgia, we already do that. And you would be right, except in Georgia today, if a member does not complete all of their hours of qualifying activities, they are not terminated from the Pathways program. So when we talk about work requirements, again, let me just clarify, we're only talking about Georgia Pathways members. This is the Medicaid expansion population. We're not talking about low-income Medicaid. We're not talking about CHIP or Peach Care for Kids, just the Pathways membership. It's a very important distinction. The estimate is that at about 70% of those 7.5 million people are going to probably lose coverage through not doing their work requirements, not uploading those timely. All right, second one, retroactive coverage. Today, we're accustomed to having both our low-income Medicaid and Pathways members, if you provide coverage to someone that isn't yet eligible, you provide services to someone that's not eligible, and they go back, the state can go back 3 months today and retroactivate their coverage. In the future state, if they're low-income Medicaid, that'll only go back 2 months. And if you're Pathways members, that can only go back 1 month. So when you talk about what that means to you as a provider, it could mean uncompensated care. It's more important than ever to check the GAMIS eligibility at the time you're providing service and, quite frankly, at the time you're getting ready to bill for the service. And then last but not least, eligibility redeterminations. Post-COVID, we have seen a significant decline in the amount of people enrolled in the Medicaid program. It has been a very large challenge to educate members about the redetermination process, which is every 12 months, because during that period of COVID, we stopped doing eligibility redeterminations. So we went for several years without having to do that. Now, all of a sudden, you've got to notify someone that it's time. You've got to send them reminders. We do this through letters. We do it through text messages. We do it through phone calls. We have community events. All of these things to try to get everyone informed about what is needed in order to do that redetermination process. But starting January 1 of 2027, if you're a Pathways member, no longer do you do that every 12 months. Now you're going to do it every 6 months. So again, we expect a lot of turnover because of that. And when there's turnover, you have individuals that are in ongoing courses of treatment that are losing some of their continuity of care, coming off of health care, coming back on to health care. That's not really good for anybody. So it's more important than ever to make sure our members are aware of that change that's coming up. That's really all I have, and hopefully I didn't put you to sleep. I'm going to turn it over to Maria to close us out. She's going to talk about rural health transformation. Oops.
Thank you, Annette. Good afternoon, everyone. I'm Maria Robbins, the Director of Rural Health and Market Initiatives, and I'll be talking about what Peach State Health Plan is doing to support our rural communities. So every community deserves access to quality health care, and I think we all know that our rural communities have the most barriers, the most challenges to obtaining quality health care access. Peach State Health Plan does this. We help support the rural communities through our unique, strong mix of local outreach, strategic partnerships, and telehealth. Peach State Health Plan has been focused on developing strategic partnership opportunities and grassroots outreach for many years. The Centene Foundation and Peach State Health Plan partnered with the Medical College of Georgia at Augusta University and provided $7.4 million of funding, seed funding, to implement, sustain the MCG 3+ Primary Care Pathway Program. It's a long name for a program that's really, we call the Peach State Scholars. Our investment funding was subsequently matched in 2021 by the Georgia Assembly for $5.2 million, and then in 2022, $8.7 million. The program allows primary care medical students to complete their medical training in 3 years and provides the opportunity to have their medical loans forgiven in exchange for their acceptance and commitment to practice in rural Georgia upon graduation. I'm proud to report that we currently have 45 Peach State Scholars in the following disciplines that you can see, most of them focused on family and internal medicine, and many in emergency medicine, peds, OB, gynecology, psychiatry, and general surgery. And as you can see on the right, the cohorts have increased. The class scholarship awards have increased significantly year over year. We've also partnered with the Morehouse School of Medicine to establish the Excellence in Equity Innovation Fund and Initiative. This initiative was launched with a $500,000 multi-year donation from Peach State Health Plan to help Morehouse enhance health outcomes and equity for Black communities across Georgia. Much of the funding has been used to support the work of Morehouse's Stature Health Leadership Institute and the Center for Maternal Health Equity. So we also have, along with the Centene Charitable Foundation, provided a $1.1 million donation to the Georgia Primary Care Association to expand school-based health center operations throughout the state. This was launched pretty much in tandem with the Governor Brian Kemp's funding allocation of $125 million to support Title I school-based health centers. And over the 3-year program, and most recently in the fall, we announced, or Georgia Primary Care Association announced the final awardees. We had 7 FQHCs that received funding earlier this year, and it brought the total to 17 FQHCs to expand school-based health center operations. And the projects really range from a combination of construction, site construction, to the purchase of medical equipment, some mobile unit equipment, to expand services and staff at these locations. And a good number of them are in rural Georgia. As you can see, it's, there's a good presence across the whole state, but there definitely is a focus on rural Georgia. We also partnered with Georgia Southern University for a workforce expansion initiative, providing $2.2 million to fund programs aimed at addressing shortfalls in nursing, behavioral health, and social work. We partnered with the National Council for Independent Living to co-establish the Barrier Removal Provider Initiative to assist providers with removing barriers to accessibility for patients with disabilities in their practice. Almost $122,000 was awarded to 16 providers across Georgia. And the projects here, again, ranged from construction building modifications to the purchase of accessible medical equipment. Through our partnership with the Georgia Healthy Families Alliance, Peach State Health Plan established a $130,000 5-year microgrant program. And the awards made through this donation really help level set in some of the communities for disparities for economically impaired individuals who are predominantly underinsured or uninsured in both rural and urban communities. We do hundreds and hundreds of events as a company. All of our departments work together, Pop Health, Quality, Community Relations, And it's hard to kind of choose which ones to talk about, but most recently, we've partnered with Grady County Schools and Phoebe Putney Health System, providing mobile units to deliver primary care screenings and behavioral health services directly to students. We've also provided free eye exams and prescription eyeglasses in partnership with other FQHCs, such as Primary Health Care Centers and Georgia Mountains. In fact, we'll be in Southwest Georgia in Thomasville next week for 2 days, and we'll be up in North Georgia in early December to provide more vision screenings and free eyeglasses if needed to children in the community. In recognition of the excellent work that Augusta University's Medical College of Georgia Center for Rural Telehealth, we provided a $15,000 grant that was used to support that program, and it's specifically tele-emergency services in rural hospitals. And through our ongoing partnership with the Global Partnership for Telehealth, we've helped expand and sustain telehealth programs across Georgia, and most recently in rural schools in Ware and Coffee County school districts. I'm really proud to talk about a new partnership that we have with Appalachia High School. Since the tragic shooting there in September of last year, Peach State Health Plan has been engaging directly with the leadership in the Barrow County School District. They were really working through tough times and still continue to heal, and we tried to be there to provide whatever services they needed when the time was right. And the time was right in early May. We partnered with them and hosted a Barrow Together Community Fest. It was a huge success. We had community partners from all over the county and provided a lot of support, and it was really an event based on hope and joy. And then we came back to Appalachia in early or late July to help with their back to school event, Back to Bold, and we provided over 1,000 pairs of name brand sneakers to the students. It was a great event. Thank you. It was a privilege to participate in all of these events, and the shoes were gone in less than 50 minutes, so very much needed. So we've been there also in tougher times. Peach State has rapidly mobilized resources and partnerships to deliver critical supplies during public health and community crisis. I don't know if you remember the baby formula shortage a few years ago, but we provided over 200 canisters of baby formula to healthcare providers across the state. They were distributed to FQHCs and pediatric and family clinics, local non-for-profit women's wellness organizations, which translated into about 4,200 meals to feed newborns. We also provided hurricane relief for when Hurricane Helene ran through the state, with about $100,000 of emergency relief to the FQHCs and their communities in most critical need. And during the COVID-19 pandemic, we provided over $100,000 of PPE equipment to hospitals, providers, and FQHCs. And with our partners, Phoebe Putnam, Memorial Hospital, Morehouse University, and Augusta University, we facilitated and hosted vaccine hesitancy panels. Well, that wraps it up for our presentation. I'm going to open the floor for questions if we have time. Thank you.
I'll let you do it. Don't mess it up.
Oh, does anyone have a question? Please raise your hand and then we'll come to you.
I'll get you right.
Good afternoon. So I would like to ask about major changes that are coming within the 2026 year that may vary from that procedure that may be from 2025, and then especially specifically within authorizations.
I couldn't really hear could you hear the question?
I don't think we heard the question well. Would you mind repeating it? Changes coming in 2026? I think that's what we heard.
Yes, I was just asking about upcoming changes for 2026. Can you hear me? Yes. Okay. That may vary from what was already being implemented in 2025, and especially specifically when it comes in regards of authorizations.
I don't think at this point in time we have any specific authorization changes coming up in 2026. We do review all of our authorization requirements on a yearly basis, and based on that, make determinations whether an authorization is still needed or certain services may need an authorization. Once that process is completed, we do submit it for approval. Once approved, all providers get a letter with notification. But at this point, I don't think anything in particular is planned. Any other questions? Okay. Well,
Hey, so I just asking about the telemedicine because it was extended through September 30th, and then you guys keep referring to it. So has it been re-extended, or we're done with telemed?
So let's see if I got your question. You're asking about telemedicine?
Yeah, so per CMS guidelines, it was extended to September 30th of this year. And I just saw that you guys kept referring to a lot of telemed. Do we know that there's another extension, or telemed's done? It's still on.
In what perspective, the telemedicine? I'm not sure I'm understanding. I'm sorry.
Can you still bill the modifier or the place of service?
Yeah,
Service 10?
yeah. We follow the guidelines that are for DCH as far as telemedicine.
Right.
Yeah, and there are services that still allow telemedicine, and you would bill it with a modifier or place of service, or both, depending on the service. Just follow the manual in the telemedicine guidelines. Yeah.
So the CMS guidelines said that telemed was suspended as of 9/30/25. So is there a different guideline that you guys are going by?
So CMS guidelines would be applicable to the Medicare and Marketplace line of business, but Medicaid still follows the DCH published guidelines on the Medicaid web portal.
Okay, thank you.
Does anyone else have a question? Oh, and please remember to fill out your survey when you have a chance, and we'll be collecting them at the door.
Thank you so much for your time and for coming to our session. Please do leave the evaluations on your way out. Thank you.